So under the umbrella of degenerative cervical myelopathy, a small umbrella is of the myelopathy which happens because of the bulging herniation or the deformity of the vertebral body, the osteophytes which might cause compression of the spinal cord, facetal joint arthropathies, hypermobility or instability or spondylolisthesis. And the other side of the umbrella, you are having the ligamentous pathologies like OPLL, that is ossified posterior longitudinal ligament, and OLF, that is ossified ligamentum flavum. Along with this, occupational and behavior factors, inherited factors, congenital factors, systemic factors, sports related factors. So these are other things that may play a vital role in patient having a degenerative cervical myelopathy. Earlier, this umbrella was termed as cervical myelopathy. Hence, over time, the terminology has changed, and rather now it comes under the wider umbrella of degenerative cervical myelopathy rather than just the cervical myelopathy. So when we talk about the compressive myelopathy, there are causes, mode-based compression. What do I mean by this? Because it may not just be that, the myelopathy is happening because of a extradural compression. It might be actually happening because of some compression that is intradural or even intramedullary. So there are some elements which are even called as non-compressive myelopathy when the patient is having the symptoms of myelopathy, but the patient is not having any compressive element or the picture radiologically. So extradural, the most commonest that we are going to talk about is the cervical spondylosis. That is a degenerative changes in the cervical spine, disc prolapse, trauma, tumor metastasis. Now, this is one important thing, that tumor or metastasis may also present to you with a picture of myelopathy. Multiple myeloma, CV junction anomalies, TB spine, epidural abscess, epidural hematoma. So infections, abscesses, hematomas can also cause the compression of the spinal cord and present as a compressive myelopathy. And this is not something that may just be pertinent to the extradural causes. Some intradural causes may also be there, like intradural tumors like neurofibromatosis, meningiomas, lipomas, sarcomas, metastasis, arachnoiditis, sarcoidosis, cervical meningitis, AVM or arteriovenous malformations, leukemic infiltrations, arachnoid cyst. So these are also the intradural causes that may cause the myelopathy. Intramedullary, intradural. Now, what I spoke over here was intradural but extramedullary. Now, if you talk about intramedullary, intradural elements that might cause the myelopathy or the pathologies, it is going to be syrinx, tumors like ependymoma, astrocytoma, hemangioblastomas, and hematomyelias. So these are the tumors, that is intradural, intramedullary tumors that may cause the myelopathy as well. Now, tandem stenosis is basically a condition in which the patient presents with stenosis concurrently in lumbar as well as cervical spine. In fact, as high as 20% of the patients who are having stenosis either in the lumbar spine or the cervical spine are going to have concurrent stenosis in the other part of the spine. So, for example, if a patient comes to you with lumbar canal stenosis, 20% of them patients would have cervical spine compression as well, and 20% of patients with cervical spine pathology or myelopathy are going to have lumbar canal stenosis as well. Natural history, so it tends to be slowly progressive and it rarely improves with non-operative modalities. Progression is characterized by step-like deterioration with periods of stable symptoms. So, this is a classic thing that happens, that is step-like deterioration. So, patient would deteriorate for some time, then plateau, then deteriorate, then plateau, then deteriorate, then plateau. So, that is how it happens. And suddenly, if the patient sustains a jerk on the neck or some trivial injury, that is when the patient will deteriorate rapidly. Prognosis, early recognition and treatment prior to any form of damage or myelomalacia or the cord edema is critical, and it is important for good clinical outcomes. So that is how you prognosticate these cases. So whenever we talk about the etiology of compression, there are different insults that might happen. That is the static insult or the dynamic insult. So what do we mean by this? So for example, the patient is having a herniated disc. That herniated disc is a static thing. So that will come under the static causes. Osteophytes, again, the osteophytes are coming out and they are going to be just present over there. Enlarged ligaments and the facetal joints are also the static causes. However, if there is some instability in the spine, or if the range of motion of the spine is increased, that comes under the category of the dynamic insult. So whenever there is a static and a dynamic insult, the microvasculature would be disrupted. Once the microvasculature is disrupted, there would be endothelial damage of the arterioles, and there would be inflammatory reactions as well. These two are interactive. That is, on the microscopic level, the endothelial damage would happen of the arterioles, and there would be a lot of inflammation that would be created, which results in the apoptosis of the neurons and the oligodendroglial cells. And this particular apoptosis causes the neuronal loss in gray matter and the demyelination of the white matter. That gives us the clinical presentation and the progression of myelopathy. So as we know, characteristically, whenever we talk about the loss of neurons, or whenever we talk about these damage on these particular neurons and these cells, the neural cells, they never regenerate. Hence, the static and dynamic insult together causes a disruption of the entire microvasculature and would cause a microscopic damage via the apoptosis. That is how you get the clinical presentation and the progression of the cervical myelopathy. Now, this particular image is a very famous image, I would say, which you would see at a lot of places. This particular image in a gist shows you that how exactly does this happen. So if ever this is a posterior longitudinal ligament, and over here towards the end, if you see, this is over here increase in size, compare it with the proximal aspect. This increase in size and some calcifications, which is demonstrated by the yellow plaguing over here, this is the ossified posterior longitudinal ligament, which is causing the compression of the cervical spine. If ever you come a bit more proximal to this, as you're seeing, there is some instability over here. C7 is a bit forward, C6 is a bit behind. So this is a retropulsion of C6, or the retrolisthesis, I would say, of the C6, which is causing the compression of the spinal cord. So this particular compression, it may not just be anterolisthesis, but it may be retrolisthesis as well. So this retrolisthesis is causing the compression of the spinal cord. Along with this, a soft disc herniation like this, which is demonstrated at C4-5 level, can also cause the compression of the spinal cord and the features of myelopathy. Posterior osteophytes from the vertebral body are very much important for us because they also cause the compression of the spinal cord. Anterior osteophytes in that place are harmless, I would say, because they don't generally cause a compression. Whenever for a long duration of time there is a compression, there is this hourglass deformity that develops, and this hourglass deformity causes, basically, there is a shortening of the vertebral body height, and as the vertebral body height shortens, this causes the compression of the spinal cord as well. Ligamentum flavum that you see over here, when there is an increase in the size of this ligamentum flavum, it causes the compression of the spinal cord over here like this. And long-term compression of the spinal cord can cause cavitation, as it is demonstrated over here. The ligamentum flavum, whenever it gets ossified, so this is ossification of the ligamentum flavum, the calcification that is being shown over here. So this also is causing the compression of the spinal cord and the features of myelopathy. So again, the compression of the spinal cord via hypertrophy of the ligamentum flavum or the ossification of the ligamentum flavum is also something important, because that can also cause the myelopathy. So these are either the anterior or the posterior causes, I would say, of myelopathy because of the compression either coming from the anterior aspect or the posterior aspect overall. Now, whenever the patients would come to you with myelopathy, there is a classification of myelopathy, which is a Neurick's classification. What do we mean by Neurick's classification? So this Neurick's classification gives you the grades of myelopathy. So this is pertinent to majorly whether the patient is employed or not, or with respect to also the gait of the patient. So this is more dependent on the clinical presentation of the patient. So Neurick's classification is a classification that basically gives us the grading pertinent to whether the patient is just having the symptoms of the root or the gait, and also it focuses on the employment of the patient. So grade 0 is when there are root symptoms only with myelopathy. That is, the patient might have compression and that is resulting in pain in a particular dermatome, or some motor weakness of a particular myotome. Grade 1 is when the patient is having signs of the spinal cord compression, but the gait is normal. Grade 2 is when the patient is having a gait difficulty, but the patient is fully employed. Grade 3 is the patient is having gait difficulties which prevents the employment and the patient works unassisted. Grade 4 is when the patient is unable to walk without any assistant. Grade 5 is when the patient is wheelchair or bedbound. And so basically the significance is, as you're understanding, we determine whether the patient is employed or not, whether the patient is walking with support or not, whether the patient is having a normal gait or not, and whether the patient is having root symptoms only or actual compression symptoms of the entire spinal cord. So this is how we determine what is a Nurix grade, and this is important because this is asked to you in your viva also. If you get a case of the cervical myelopathy, Nurix grading is something that is important to be given in the diagnosis. Ranawat's classification, historically, this is also important. There are three different classes. Class 1 is when the patient is having pain, no deficit. Class 2 is when the patient would have a subjective weakness. Clinically, you are going to elicit hyperreflexia and dysthesias. Class 3 is when the patient is having objective weakness with long track signs. However, the patient is ambulatory. 3B is when the patient has got objective weakness with long track signs and the patient is not ambulatory. So these are the different grading with respect to the Ranawat's classification system.